now we are going to consider an ECG for rhythm analysis. You will be concentrating mainly on the rhythm, but other findings will also be sought after, because you can't say that ECG can have only rhythm abnormality, other abnormalities can also be there. So at one look you can say that it has a bradycardia. The rate is quite low, but even when it is a bradycardia, it's not a regular rhythm. There is what we call as group beating. These two beats are nearer to each other because this RR interval more, this RR interval is less. This is again long, this is short. So in the setting of bradycardia, you are having a group beating. Now we will look at the cause of the group beating. If you look at this QRS, there is no preceding P wave. With such a long interval before that, there is no preceding P wave. While this QRS has a P wave. So in the setting of severe bradycardia, when you have a QRS without a P wave, we call it an escape beat. With a wide QRS, you might think that is a ventricular escape beat. But there is a problem. This QRS is also wide. So if sinus QRS is also wide, then you can't be 100% sure that this is a ventricular escape beat. Moreover, these are similar beats. So you have to think of other possibilities also. Similar rhythm is known as escape capture bigeminy. Escape followed by a sinus capture. This is a sinus capture beat with a reasonably normal PR interval. Now, why is the QRS wide in all the leads, all the complexes, not just the escape beat, but also in the sinus beats also? You look at the basic ECG. You can see that there is a M-shaped pattern in lead 1, AVL, and V6, which would suggest left bundle branch block pattern. So one possibility you can think is this person had a pre-existing left bundle branch block pattern, conduction system abnormality below the AV node. So it could be a pan-conduction system disease because sinus bradycardia is there. And this escape beat in that context could be junctional also, because junctional escape beat will not have a P wave and it will have same configuration as the sinus beat. This wide beat is probably not due to a ventricular origin of the escape beat, but because of pre-existing bundle branch block. Here you can see that there is a P wave. So this is probably the sinus beat and this is probably the escape beat. But with only two beats seen in a given lead, you can't be completely sure. You have to look at the rhythm strip. Similarly, here there is a P wave is seen here. There is no P wave. So of the group beats, you are seeing these two beats together in the ECG, except the rhythm strip. So you can't identify the abnormality from the ECG, regular part of the ECG alone. But carefully you can see there is a P wave here, this is P wave, there is no P wave here. So this is a sinus beat, this is not a sinus beat. So naturally you have to think of an escape beat. Even if this is not there, you have to think of this as an escape beat. But you have to be sure by the rhythm strip. So this ECG is a complex ECG which shows conduction or rather pan-conduction system disease. You have sinus bradycardia and junctional escape. And even junctional escape is delayed because the interval here is quite long. 1, 2, 3, 4, 5, 6, 7 divisions. In a junctional escape, you expect a rate of around 60 per minute. In a junctional escape, you expect a rate of 60 per minute. But this is much lower than that. So it could be a ventricular escape. If it is a junctional escape, you can definitely say that the junctional node is also diseased. Otherwise, such a delay in escape would not occur. Why we think of junctional escape, we have discussed earlier, because of the bundle branch block pattern. So it could be a progressive disease, that is in pan conduction disease, you can have bundle branch block initially and then the AV node can be involved, then the sinus node can also be involved, binodal disease. So this person is likely to have Stokes-Adam attacks because it's an infrahisian disease combined with suprahisian disease. So you have to evaluate fully for any reversible causes, and if there are no reversible causes and if the person is symptomatic, then this person might need a permanent pacemaker, which will be decided by further investigation only.